I would like to welcome us all over to this meeting, another one of our monthly meetings for the Nigerian Society for Colorectal Disorders. We are grateful to have our teachers, our professors, and colleagues in the house, especially as our international rapporteurs, Mr. Augustine, Dr. Augustine, and then Mr. Emmanuel Eguara. We are also very delighted to have Professor David Irabor from the College of Medicine, University of Ibadan, and University of College Hospital Ibadan, and here to give us a discussion on the role of molecular testing and personalized medicine in prostate cancers with the Nigerian's perspective in mind. And without further ado, I would like to invite Professor Irabor to give this talk. You're welcome, sir.
So today's talk is about the role of molecular testing and personalized medicine in colorectal cancer, the Nigerian perspective. All right, thank you. So colorectal cancer used to be a disease of developed Western countries. Now it's one of the top 5 cancers in Nigerians, actually top 3 if you look at it closely, both male and female. Now, the manifestation of this disease depends on the location. Thus, right-sided tumors present differently from left-sided tumors, likewise rectal tumors. What are the etiological factors to this disease? Environment, chiefly the diet, could be familial, could be genetic, and most of the time, it is sporadic. How does this thing develop? The adenoma carcinoma sequence described by Vogelstein and Ferron initially was an eye-opener, but was later recognized to be a bit simplistic. And that was because all they dealt with then was villous, tubular, tubulovillous adenomas. They hadn't taken into consideration then hyperplastic polyps, which people initially thought were not malignant. But now we know that serrated adenomas, which are part of the hyperplastic polyps group, now shown to be quite malignant. And these are some of the things that piqued the interest of researchers, that this colorectal cancer is actually a heterogeneous tumor, and it arises as a result of accumulation of acquired genetic and epigenetic changes, leading to the transformation of normal glandular epithelial cells into invasive adenocarcinoma. There are 4 kinds of genomic or epigenomic instability in colorectal cancer. These 4 groups are not totally exhaustive, but most of the time, these are the pathways that most researchers have concentrated on. So you have chromosomal instability, CIN, microsatellite instability, MSI, CpG-Alan methylator phenotype, CIMP, and then you could also have a global DNA hypomethylation. So why did people even think about molecular testing? Apparently for malignancies, this concept had come up quite a long time ago. But it's only now that people are honing down on things like colorectal cancer. In the past, tested melanomas, we tested breast cancer. But it was seen just by plain observation that not all colorectal cancers behave the same. You have some with good tumor biology, which whatever you do, patients live longer. And you have some bad tumor biology in which before you know it, the patient has succumbed to the disease. You have aggressive behavior, non-aggressive behavior. There are different routes or patterns of metastasis. And in some cases, some tumors will respond well to chemo, and some others, you just won't get a response at all. We also know that you could have racial differences or racial disparities, which we would talk about as we go on. It is now known that African Americans have an increased incidence and mortality than Caucasians. A study by Gouda et al., which was done in 2015, sort of isolated some novel mutated genes in African Americans. They weren't found in any other race but African Americans. One of them was folliculin, the other one was FR6 or something. So it means that there are some things in some races that could drive their colon cancer, and which is not found in any other race. In sub-Saharan Africa, especially in Nigeria, we have noticed that this concept of frozen pelvis, especially with patients that have rectal cancer, you want to go and operate and find that the whole place is rigid. You don't even have any space to operate. Things like sheets of tumor cells in the peritoneum, like a carpet, carcinomatosis peritonei, seems to be more common in Nigerians. We know we have more rectal cancer than colon cancer, sometimes up to a ratio of 2:1. And then favorable histopathology with increased mucinous and signet ring subtypes. We have also found out that up to 20% incidence, we see them in patients under 30 years old. And that is something. And it is known that those ones are usually a little bit more aggressive than those seen in older patients. And of course, most of us acknowledge that adenomatous polyps are rare in sub-Saharan Africa. Not to say we're not seeing them now. We are seeing a lot more now. But when you do see them, it's like big news. It's like, whoa, I have to report this. This is an adenomatous polyp in the Nigerian. So we still agree that we don't have as many cases of adenomatous polyps as you have in Caucasians. Now, these are the commonly tested molecular markers. Of course, as a good general going to war, you need to know the weaknesses and strengths of your foes, your enemy. You need to know which route they're coming from. Is it by air, road, or is it by sea? This is why we need to study some of these molecular markers. If by blocking their routes of action, you can prolong a patient's life or even cure the colorectal cancer, then great. So many of these markers now have come to the fore. Of course, there are several others that I haven't mentioned, but these are the commonly tested molecular markers. Microsatellite instability, the BRAF, the KRAS, epidermal growth factor receptors, vascular epidermal growth factors. These are some of the things that we test now, and newer agents are being manufactured to take care of some of these pathways. Why? Why should we even test anybody at all? Biomarker testing can reveal the interventions that are not likely to elicit a response. So don't waste your time giving patients ineffective, expensive, and toxic therapies. From the get-go, know what will benefit your patient. We know that the wild type of BRAF V600E has a poor response to anti-EGFR. So if your patient has wildcard overexpression of that, there's no point giving them expensive anti-EGFR because it will not work and it might even be toxic to the patient. There is this talk about microsatellite instability high and poor response to 5-FU. Some people think it's still controversial, but many more publications seem to lean on the side that MSHI and 5-FU are not friends. They don't go well together. HER2 amplification is also a predictor of negative anti-EGFR. So if a patient's tumor exhibits HER2 neu, then it's better not to give them anti-EGFR monoclonal antibodies. We do know that targeted, personalized treatment does increase survival in patients with metastatic colorectal cancer. That has been proven. And it's not just talking about 4 or 5 months. Sometimes when they're used judiciously, the patient could also live for about 24 to 30 months extra. 2 to 2.5 years is not small beans. So the significance of molecular testing and personalized treatment underscores the fact that one size, one form of treatment does not fit all colorectal cancer patients. So which patients would benefit from targeted therapy? Obviously, it's not for everybody. So the patients with advanced or metastatic colorectal cancer are best suited for tailored, personalized, or targeted therapy. And this is right up the alley of our Nigerian patients, where late presentation is the rule rather than the exception. Targeted therapy has been shown to give metastatic colorectal cancer at least 4 to 6 months extra initially when they first started in the 1990s. But up to the 2000s now, 2020 upwards, can rest assured that when it's judicially administered, patients may live for an extra 2 years or more. So what do we have in Nigeria? Do we have patients who may require this drug? And we do know that quite a number of Nigerian researchers, they have tried to illustrate the molecular biology of native Nigerian colorectal cancer patients. Now, some of the publications in which you will see that I'll list now, I put them in the order in which they were published. But please forgive me if I did not include your study, because in order to not bore you with all these things, I just put the ones I felt might be actually relevant to the talk I'm giving. The first one that came out, that was in 2000, by Adebamawo et al. This was a case report on hereditary non-polyposis colon cancer. And this pilot study in Ibadan resected tumors from 5 patients who were subjected to microsatellite analysis. 2 out of 5 patients exhibited microsatellite instability. Though the number is really small, but it was a pilot study. So they felt that we should look into this more. It's possible that HMPCC may be more frequent than hitherto thought in Nigerian colorectal cancer patients. Duduyemi in 2013, also from Ibadan, analyzed 26 archival paraffin tissue blocks. And they identified the loss of mismatch repair gene, MLH1 and MSH2, in 23% of the specimens. And these were particularly young individuals. So once again, the study is moving towards the fact that defects of mismatch repair are important in colorectal carcinogenesis in Nigeria. Abdul Karim from Lagos, she's done quite a lot on colorectal cancer, analyzed KRAS and BRAF mutations in Nigerian colorectal cancer. And they started off with 200 archival paraffin blocks pyrosequencing them for assessment of KRAS codons 12, 13, and 61, and BRAF V600. They were successful in 112 out of the 200 blocks. And the study showed that 21% of Nigerian colorectal cancer carry a KRAS mutation, which is half the rate in Caucasians. And BRAF mutations occur in 4.5% of Nigerian colorectal cancer. I collaborated with some people from Vanderbilt University, Tennessee, using archival paraffin blocks also. And out of the 114, 83 were found to be suitable for testing. MSH high was found in 43% of Nigerian cases of colorectal cancer. Other things that were seen in those tissue blocks: poor differentiation, invasive growth up to 94%, and a high prevalence of mucinous and signet ring types. The high prevalence of mucinous and signet ring types have been described by many authors who have written papers on colorectal cancer in Nigeria. And mucinous and signet ring types are said to be very aggressive. So the study, which I collaborated with, concluded that MSI colorectal cancer is common in West Africa. Now, West Africa, not just Nigeria, because these collaborators from Vanderbilt had also done a study with Dakubo in Ghana. That was in 2013. And they also found out that MSHI colorectal cancer was high, up to 41% in Ghanaian colorectal cancer specimens. So MSIH colorectal cancer is common in West Africa. So take the two most populous, most educated, most forward countries in West Africa, Nigeria and Ghana. It shows that MSHI is something we have to contend with. Dairo et al. In Kano showed that MSI occurred in 53%. They did not specify whether it was high, stable, or not. But they know that 53% of their paraffin blocks showed microsatellite instability. Alatiche from Ife has also done quite some work on colorectal cancer. And again, archival paraffin blocks. MSH high was 28.1%. They studied 64 paraffin blocks, and 18 out of them were MSH high, consistent with the rate of mismatch repair protein deficiency by immunohistochemistry, 20 out of 94 blocks. So what have we gleaned from the work done by these Nigerians? Microsatellite instability has been published to occur in at least 23 to 53% of Nigerian colorectal cancer. MSH high seen in 28.1 to 43%. KRAS 21%, BRAF 4.5%. So what do these figures mean for us and our practice? I alluded to the fact before that patients with MSH high colorectal cancer appear to have ineffectual or even detrimental responses to 5-fluorouracil-based adjuvant chemotherapy. Some of them had advised that we use irinotecan instead. And we all accept that 5-FU is the cornerstone, if not the bedrock, of most of the combination chemotherapy we administer to our patients. Folfox, Folfiri, Capeox, Zelox. The question is, are we doing the right thing in 50% of our patients? If we say that MSI, we see them in at least 50% or 53%, and MSI high is seen in 43%, Must we just blunderbuss treat everybody by putting 5FU? When many publications are talking about the fact that they do not do well with 5FU-based adjuvant chemotherapy. So maybe we should start looking at irinotecan, maybe Irinox or something else to treat our patients with colorectal cancer. The study of BRAF and KRAS by Abdul Karim et al. Suggests that Nigerian patients may benefit more from anti-EGFR therapy because Europeans or Caucasians, they have an overexpression, usually up to about 40%, 43% of cases. So we have KRAS in about 20 or panitumumab than Caucasians. And also the significant MSIH presence with mucinous and a signet ring subtypes may also mean that the etiopathogenesis of our colorectal cancer might be a Lynch syndrome type of etiology. We'll wait and see. So what are the challenges that we face here in Nigeria? You could see that most of the Nigerian studies used archival paraffin blocks, making them retrospective studies, really. And it's difficult to do prospective studies because the logistics are difficult and the tests are expensive. Where are the labs to do the tests? There is a specialist diagnostic laboratory, I think in Lagos, in Luth, where they can do immunohistochemistry. The special diagnostic lab in UCH Ibadan also can do immunohistochemistry. But other things like pyrosequencing, next generation sequencing, it's a bit too much for them now. But good news is that sometimes immunohistochemistry can do some basic things like the KRAS, the BRAF, and microsatellite instability. But most of us send the blocks overseas so that, is it a case of us still just being collection centers and sending our own raw data to be examined abroad? Molecular testing guidelines for colorectal cancer suggest that at least 3 tests should be done. That's MSI, BRAF, and KRAS. Now, those tests are not cheap. Immunohistochemistry for MSI, at least in Lagos, costs 104,000 naira. Some of these tests, by the time you do all 3, you may have spent up to like $500. If you convert that into our own currency, naira, we're talking about something about 370,000 naira just to do the tests. Now, who pays for these tests? Does our National Health Insurance Service, will it take care of this? That is doubtful. Should the cost be passed on to the patient? Affluent patients, yes, they would do that easily. But not everybody can afford to do this test. Again, should one analyze each specimen individually or batch them until a significant number is reached? I spoke with one of our pathologists, and he told me that if you do each specimen individually, it's going to cost a lot more. So sometimes it's good to batch them so that you can run everything at the same time. Well, the problem with that is, won't that delay the treatment of an index case? Let us assume that in 1 year, maybe we operate on about 48 or 50 patients with colorectal cancer. Should we wait until December after operating on somebody in May before we start analyzing? So these are some of the problems or challenges we might face here. If the tests do come in kits that require that you have to fill everything before it is run, then we may have a problem. Not unless we agree to a central lab in which all teaching hospitals or all people who operate on patients with colon or rectal cancer can now send the specimens to that central laboratory so that the kits can fill up and we can run the tests immediately. We know the drugs are expensive and not entirely free of serious side effects. Cetuximab and panitumumab cost about $2,000 per 2-weekly dose. And these are supposed to be given until disease progression or unacceptable toxicity occurs. Yes, that's why I put that there. $2,000 is about 1.6 million naira every 2 weeks. Unless you're a senator or a minister or a governor, even a professor of surgery, I doubt if you can afford that kind of money. Factor in the fact that you still have to combine them with the prescribed cytotoxic chemotherapy, which again are not cheap. So in Nigeria, I say again, a family could be impoverished because of targeted therapy. Yes, the patient could gain an extra 2.5 years, but then what will be the quality of life after? Would they be living in abject poverty? That needs to be thought about. I can't leave this topic without talking about the magic drug, the latest breaking news about the drugs making wave as an effective monotherapy for metastatic rectal cancer. Gentlemen and ladies, please welcome dostarlimab. That was a drug that was tested on 12 patients with locally advanced rectal cancer. And when they completed the treatment with dostarlimab, they've had a complete clinical response. No evidence at all of tumor on MRI, PET scan, endoscopy, digital rectal exam, or biopsy. And at the time in which the paper came out by Sachek et al., no patient had received chemoradiotherapy, no patient had undergone surgery, and no cases of progression or recurrence had been reported. Talking about a follow-up range of 6 to 25 months, and no adverse events of grade 3 or higher have been reported. Indeed, it's a miracle drug for now. For now. 12 patients, small, but I'm sure more tests have been done on the wider range of patients. And if it turns out to be everything we wish it would be, then metastatic rectal cancer has found its treatment. So this will be useful for Nigerian colorectal cancer. Like we said, most of our patients present late. Most of our patients have metastatic disease. Most of our patients have more rectal cancer than colon cancer. So if dostarlimab is the one to use, super. But dostarlimab is expensive. It costs $11,000 per 2 weekly shot. So there is a huge mountain to climb before targeted therapy becomes routine in Nigeria. But since this form of treatment is mainly for metastatic colorectal cancer, let us improve our efforts at population screening first. And let's try to pick up our colorectal cancer early so that we can treat them with conventional cytotoxic chemotherapy. Targeted therapy can then be reserved for those that progress in spite of apparently adequate treatment, or those with first-line cytotoxic chemotherapy resistance or failure. I rest my case here. Thank you for listening. I'll stop here.
Thank you very much, Professor Irabor, for this erudite presentation. And there's a lot of food for thought from what you've said there. You've given us both the academic and the practical as well as the human side of this story. And I'm sure there are lots of questions and comments. I'd like to hand over, with the permission of the House, to Mr. Emmanuel Gwari to handle the question and answer session.
Yeah, thanks very much, Professor Adejumo and Professor Adeye. And thanks a lot, Professor Irabor, for that very enlightening and sobering at the same time conversation. Your data is very sincere and direct and honest presentation, and we appreciate that. Thank you so much for the time you put into collecting this information and presenting it in such a succinct manner. Yeah, I just have a few questions or things that was bothering me in the presentation of patients from Nigeria. You did say in the study, Professor Irabor, yes, that the frozen pelvis and carcinomatosis and carcinomatosis peritonei were very common in Nigerians in terms of the and then the rectal cancer is more common than colon cancer. And my question is, why do we think this is? Because I know that mucinous mucinous cancers will obviously lead to more carcinomatosis and frozen pelvis. Is it a question of late presentation, late diagnosis? Why do we think that is common in Nigerians?
Okay, should I answer straight away, sir?
Oh, yeah.
Okay.
Yeah. And if there are other questions, please, can we, okay, I'll just check the comment site and see if there are questions there too, why you answer this. Yeah.
Okay, you would remember sometime last month, Prof, that I did ask the question, but for some reason it went under the radar and wasn't answered. That why do we have more rectal cancers than colon cancers? And it is a fact that in sub-Saharan Africa, all the publications from Nigeria, Ghana have shown that almost 2-to-1. And people are now thinking that rectal cancer must have its own separate etiology from colon cancer. And that's one thing we haven't really been able to grasp, to hold on to. But we do know that without a fact, we see a lot more rectal cancer patients than colon cancer. And these are the ones who do not want surgery, who actually wait until they have problems, maybe they become anemic, or they have liver mets, or frozen pelvis, peritoneal mets, before they come. And many times all you can do is just give them a colostomy and start them on chemo. Now, the fact of having frozen pelvis or carcinomatosis peritoneal, yes, a fact might be because they present late. Another fact might just be because Nigerian colorectal cancer is aggressive. Now, some have talked about the serrated pathway, adenoma pathway. The serrated adenoma is one which is easy to miss during endoscopy because they're usually sessile. So you might not know, and the thing is there is growing until it gets to a stage in which it now becomes really symptomatic. And they're supposed to be even more aggressive than the other types. So I think it is possible that we, for some reason, just have aggressive tumors. it's not all the time that we present late. There are some people who may come in early, and before you know it, they have liver mets, ascites, all sorts of funny metastatic presentations, even to the spine. We've seen to the lungs just recently. Nothing in the abdomen, just went straight to the lungs. So sometimes I think Nigerian or African colorectal cancer needs a lot more analysis to be able to get any good answers. That's about as much as I can tell you about that, sir.
Thank you so much. Thank you, my brother. My other question, I'm just thinking in my heart is, are we really doing enough endoscopies to have a reliable data to determine the incidence of rectal vis-a-vis colorectal? And many people that will have the skills to do left-sided endoscopies without completing it, does that lead to more pick-up rates on the left side than the right? And just the issue of the serrated adenoma you brought up, again, that highlights, the difficulty, because you actually need, very sensitive techniques, a chromoendoscopy or very high definition colonoscopes to be able to identify these small serrated adenomas that are really sessile and endophytic. So my question, you've just presented and you've put your finger on all the problems that we have in terms of the cost of the test and in terms of the fact that most of these molecular biomarkers are, and the treatment thereof are for metastatic cancers. And then you have just presented the cost also, $104K for treat the test.
Immunohistochemistry, the test.
Yeah, immunohistochemistry, for a family that's already facing this kind of death sentence. It's very sobering. So what can we do? Because like you said, there is strength in numbers, and Nigeria is a big country. And I was just wondering, these are the areas we really need to be talking about. You talked about pulling data, pulling samples to get, to actually bring down the cost. But again, time is of the essence. If you really want to utilize any of these, 6 weeks is your window of opportunity. From when you perform surgery to determine what modality of treatment or drugs to use for these patients. So how do we go about that as a collective? Because you are the professor in Ibadan, and I think maybe how can we, come together to determine, because cost is the issue. Can we talk to industry to bring down the price of this in Nigeria? Is it possible?
There's always something called the Nigerian factor, sir, which I'm not sure was alluded to also last month, or maybe I heard it in another forum. They talked about Ethicon wanting to come down to give us some training on something, some instruments for laparoscopic surgery or something, I'm not sure. And NAFDAC was saying that they had to send a group of Nigerians to their factory in England or something to go and make sure that the process of manufacturing is sound. These are some of the things that delay any useful kind of benevolence that we deserve. Somebody is trying to help and you putting obstacles in their path. This is what happens here in Nigeria. Now, the cost of those drugs, it's everywhere, sir. Even in the US, even in the UK, these costs are, for average people, they're quite heavy. I know insurance helps to offset some of it, but here in Nigeria, the Nigerian health insurance probably will not look at that side at all. Even It's only recently that NHIS has started covering for the basic cytotoxic chemotherapy. Just recently, maybe last year or so, and said, okay, they'll cover it up to maybe 200,000 and the patient pays the rest. And that's just a drop in the ocean, actually. So, but I think a lot more noise needs to be made about screening colonoscopy, because all we're doing is we're always playing catch up. Is when the patient has symptoms and I say, go and do a colonoscopy, and they'll say, oops, this patient has transverse colon tumor, or this patient has this or that. Screening colonoscopy, not yet, sir. I don't know when we'll ever get to it.
Yeah, no, I quite I identify with your concerns, actually, because the other point you made was that adenomatous polyps are not common in Nigeria. And
Yes.
that brings my question. Is it because exactly because we are not performing enough screening? Because you talked about the adenomatous polyposis adenoma carcinoma sequence, which, I mean, we know that that's not the only cause now, because of other mutations that could occur. But it still stands to reason that most of these polyps will begin as a form of polyp, either adenomatous polyp, TVA, or villous adenoma, or serrated. But these things, if they're diagnosed on endoscopy early enough, it will prevent them from going to cancer. So when we say that they are not common, is it that we actually miss them? That by the time these patients are symptomatic and they present to us, the polyps have already transformed or progressed to carcinoma or gone through that sequence?
Well, I can categorically say that they are not common. And the reason is that most of the time when you do colon cancer surgery, right hemicolectomies, transverse colectomies, left hemis, sigmoid colectomies, many times you take far more tissue than where the site of the tumor is, because of course you have to do an anatomical resection, making sure that areas where the lymph nodes would be in the mesentery are also taken. And many papers have shown that when they get the specimens in the pathology lab, they cut everything open. Nobody has said that all these specimens, they've seen tumors or polyps in them, apart from the site in which the tumor is.
Yes.
Now, Alatishe in Ife actually did a prospective study, and I think adenomatous tumors were seen in less than 4%. There are quite a lot of inflammatory or juvenile polyps. They were biopsied, and all of them turned out to be benign. The true ones with dysplasia were less than 4%, I think, and they must have scoped more than 600 patients. So these are some of the reasons why when you see a patient that really has familial adenomatous polyposis, there are thousands of polyps in the colon. It's not a case of most serrated adenomas, you see one or two, and they grow quickly. But when we really talk about adenomatous polyposis, if it's not the true familial adenomatous polyposis, at least you have some other ones, MUYTH type, that you may have hundreds, maybe not thousands, but there will still be polyps in other segments, in other parts of the large bowel.
Okay, yeah, I just want to get that clear. So are we talking of adenomatous polyps or adenomatous polyposis coli? Because if you're talking of APC, then I can understand that you're looking for neighboring polyps, to the tumor, to the primary tumor. Yes. But yeah, if it's just solitary adenomatous polyps that transform or progress to cancer, you're very unlikely to see any other polyp in that vicinity.
True. I agree with that. Yes.
Okay. Anyway, I think we welcome some other questions, but I should apologize to Patrick Igwe here. He said you omitted one study by Olusegun Alatise about the molecular and phenotypic profiling of colorectal cancer patients in West Africa.
That is the paper you refer to now.
Okay, all right.
Did I?
Well, that's he just said it here that looks like he said, I think you omitted this paper. It was a prospectively done international collaboration.
It was. I said that 90% of them, 90%. His was prospectively done. I agree with that.
Okay.
Alatishe, I think, yeah. This is it.
Okay, so we take that back then. So you actually to that paper, yes. Okay, thank you so much, Professor Irabor. There are a few hands up there. So we'll start from Dr. Omore Dion Irowa from UBTH.
Good evening, everyone. I want to thank Professor Irabor for the presentation. But I think mine is just to look at how we can make things better for our patients and how to improve care. I just suggested that I put it on the charts that our society should be able to, ramp up the issue of testing for patients. I mean, we have some international faculties, how we can make things better for our patients. We may not be able to get there yet because of the bottlenecks we have with the government and its officials, but we can actually be able to draft documents for us to be able to engage with the government. And on that ground, I just suggest that we should have a small committee of having to engage government on the need for us to do what is correct. That is one, sir. Then the other one is that anytime we look at the colon, most of the time, looking at the notorious poly, whether we have enough of it, we are not doing screening colonoscopy yet. When we start doing screening colonoscopy the way it ought to be done, the story will change completely. I just look at that very clearly. And of course, I think our people are going to be averse to screening colonoscopy. In where we work, the management of the hospital have left colonoscopy open for people to come. Nobody, no staff came. It was funny, but nobody came. I mean, only patients who are symptomatic probably come for us to do colonoscopy. For very few patients, particularly those who have been travel abroad, who need to do screening, but because of one, they couldn't go back to do screening. Usually see them coming on their own to do screening colonoscopy. So I think maybe we should try to look for ways as a society to start advocating and pushing that we should have a screening colonoscopy domicile in those centers where obviously they have a running endoscopic service. So I think that we should try and do as a people. But more importantly, sir, I just believe very strongly the immunohistochemistry testing, we can make it better, we can make it more useful to the patient rather than getting the results and morally writing up this what we found. Because most of these papers and the reviews that we have, some of them may not ultimately benefit the patient aside from just having figures and say, oh, these have particular limitations, have limitations. But we should be able, even going from here, have a small committee or so, decide on we can do testing real time. If we pull our specimen from all centers, there will not be any need for batching. Because if Prof is doing colon surgery in Ibadan, somebody is doing in Kano, if we bring, that would be a good number. So wherever we finally find ourselves to get the test done, we have good numbers. So your result can return to us within that period of 6 weeks if we need to work it out properly. And that will be that we can be able to then, as we are treating the patient, we are gathering enough data for this patient. So in long run, about a year or two, we have enough to say, okay, this is what we are doing, this is what we got from this result, and this is how we use it for patients. Company generally, industries is difficult to engage with, but we will come to do that. We let us draw a protocol on how to engage them. If we do not do it, we will discuss this matter in the next 5 years, the way we are discussing it now, because we will move forward. Even if you are going to get a draft document on how to do that, even if you are going to have a push, we will be making progress, even though slowly, and in the long run, our patient will benefit from this treatment. I will thank Prof again for this wonderful presentation, and this is an eye-opener We need to do more for our patients. We need to get engaged more. And of course, if we do what is correct, I mean, we can get more information than we are doing now, particularly the issue of screening colonoscopy. We need to look for a way to get it done real time in all the centers. And of course, maybe our results will look a little bit different if we can get that done. Thank you very much, sir.
Thank you. I agree with your submissions, totally.
Thank you so much. That was very sensible and a very vital contribution there. And Professor Adeyeye.
Good day, everybody. Can you hear me?
Yes, we can hear you.
Okay. Thank you very much, sir, for the opportunity to speak. Thank you again, Professor Irabor, for the lecture. I just want to take a leaf from what my brother, Dr. Ra, just mentioned. I know there are lots to talk about, but I'll just focus on one particular issue, and that's about immunohistochemistry testing. The NCN guidelines now recommend that all colorectal cancer patients should at least have testing for microsatellite instability or for mismatch repair deficiency for all patients, and because of its prognostic and therapeutic importance. And if we take a leaf from what happens for our breast cancer patients, where routinely now they should have immunohistochemistry as part of their evaluation, where HER2 status determines whether a patient gets Herceptin, Perjeta, and other medications like that. I think we eventually may end up evolving in that kind of sequence in our colorectal cancer patients. I believe that volume will drive down prices. And I believe that by the time we're able to show evidence that this actually works, it probably will get incorporated even into our guidelines and also with our policymakers. 5-10 years ago, it was very difficult to get the patient to be on Herceptin because of the prohibitive cost. But now in some teaching hospitals in Nigeria, the cost of Herceptin has been driven down based on the pilot scheme between the government and the manufacturers to bring this at a subsidized price. The same thing to immunohistochemistry was very difficult to get for some of our patients some time ago. But now with the volume that it has driven the prices down. So I believe that if, as a minimum, we're able to do immunohistochemistry for all our patients who have colorectal cancer to determine if they have microsatellite instability, it will drive down the price. It will also show the need for those targeted, especially immunotherapy, in which case eventually, by the time those come to the market with the volume, so you even end up driving down the prices. The other thing I want to say on a scientific basis, to also for policymakers, that when we already have evidence from 2000 from Professor Broad's presentation of different studies showing the molecular profile of colorectal cancer in Nigeria, I don't think there's been any systematic review or meta-analysis of this data. I think it's probably worth considering as a society to study this and collect all those results together and see if they will make sense, both for academic purposes and also for policymakers too. And that can also drive the discussion forward. That's what I feel we should consider strongly for this as a takeout from this presentation. The other things I want to say, but I know there are a lot of people who want to talk and we don't have much time. Thank you so much.
Thank you, Professor Adeyeye. Thank you so much for that comment. And I just go back to another question here. Where is that question? Yeah, so thank you, Prof, for the enlightening presentation. That's from Anne Olute, Dr. Anne Olute. Says, why is it that the targeted therapy is for metastatic cancers? Would it not be beneficial for those who can afford, if the molecular pattern is known and managed early, would it not be curative? Thank you.
Thank you for that question, Anne Olute. There's a concept about not over-treating patients. If you get a stage 1 and 2 colon cancer, you know that stage 1 colon cancer, probably surgery might be okay, and then you watch the patient for a while. Stage 2, you do surgery and you give them the usual cytotoxic chemotherapy. You reserve your tailored therapy for those that have escaped and have reached either the liver, the peritoneum, something. Like I said earlier, these things are expensive and they could also be toxic. So if tests have been done and shown that those who really benefit are those with metastatic colorectal cancer, then we keep them for such patients. I know the Nigerian thing is like, yes, why don't you just eradicate and kill the whole cancer cells? But if it's been shown that it's not beneficial to those ones, then we'll stick with the normal protocol for stages 1 and 2 and concentrate on the metastatic colon or rectal cancer.
Yeah, thank you so much, Prof. And I think that brings us back to what we discussed in the past about having a standardized histological reporting system where we can actually have a minimum data set in the reports. For example, MSI instability or KRAS mutation, all those things should be part of a standardized histological report, so that, like, just like Professor Adeyeye said there, that if we do that, there is strength in numbers. You know, the more of these things you do, the price should be coming down. You know, we should drive down the price. But then there has to be a concerted effort by all of us to actually present a united force to negotiate. Because if everybody is doing the negotiation with the industry, you really won't get anywhere. But an association like this, so that's when Dr. Morodion and Dr. Irabor suggested the formation of a committee to look at this. I think we should be looking at that to create a force. So we are the primary treaters. We are the people in the front line in treating colorectal cancer in this country, and we want to decide how this should go. You know, sit at the table with industry that manufacture this. I think we'll be able to achieve some results with that. But again, it comes from the, first of all, having a standardized reporting system. Everybody ascribes to that. How many lymph nodes do you need to evaluate in a report? You know, at least 12, you know, to look at it. How was the apical lymph node marked? How is this? So that it helps us to standardize the report as we go forward. But we have to begin from this place. And I agree with Dr. Irabor, most of these treatments are very expensive. Even nice guidelines in the UK will not approve of these expensive medications for treating everybody. So they are targeted for specific people because of their toxicity and because of the cost also. Dr. Emeka Irabor, or Professor Irabor, yes, congratulations. I think we got your message the last time on your elevation. You have your hand is raised up there.
Thank you so much. Good afternoon, good evening, depending on where you are. I would like to appreciate Professor Irabor for the very brief and precise presentation. I also commend all his effort. I have diligently followed a lot of his research works related to colorectal cancer. I commend all those who have made publications related to molecular filing of colorectal cancer in Nigeria. You know, it's an expensive thing. It's really an expensive thing, but at the end of it, we need data so to be able to make policy decisions. And like we know, immunohistochemistry is inferior to next generation sequencing. So we need to patiently build up the data we have before we can make far-reaching policies based on them. That's in line with evidence-based practice. So what we have currently is a low level of evidence. I also want to agree with Dr. Adeyeye that a meta-analysis of the works that have been done so far, at least would help us moving forward. And I'd like to share information regarding polyp. Sir, Prof. Irabor, I beg to differ with you regarding polyp detection in Nigeria with based on evidence. We did a systematic review, which is published with the Journal of Nigerian Journal of Gastroenterology and Hepatology. It was an invited review from Sogin. So we found regional variation in polyp detection, and this is based on the endoscopies practicing in those areas, from as low as less than 10%, that's polyp detection rate, to 30-something, in the series that were done in mostly symptomatic population. But on a personal note, we seem to be only, I have been able to publish the only study in Nigeria on a purely asymptomatic population. And that was from a multinational firm that was doing screening colonoscopy in Port Harcourt. Even though the number is a humble amount, but from that, we're able to detect 53.7% polyp detection rate. By this, I mean in patients who were above 50 years, that's the prior screening age from 50 years and above. And the adenoma detection rate was 28.8%. So that tells us something, that we are not detecting, or we're not doing enough of these investigations to be able to make generalizing statements. But all the same, that if screening colonoscopy was done, it is highly probable that the rates that are that we would not be too far away from what it is in the West. I'm not saying that our values will be like that in the West, but we will have a more accurate finding. So I wouldn't like to take up more time. I just want to commend all in the effort that we all keep chipping in a bit, and then a little bit of more information. We're trying to currently doing a meta-analysis that's for Africa. We see that there are limited colonoscopy studies. If you search literature, there are limited colonoscopy studies from Africa. I'm not talking of Nigeria now, West Africa. I mean from Africa. So we're gaining momentum, and I encourage anybody who's doing colonoscopy to try to gather their data and publish it. It will help when somebody is trying to do a meta-analysis for us to be moving forward in an evidence-based manner towards better care towards our patients. Thank you very much.
Thank you so much, Prof. Yeah, I think there are two other questions that were published in the chat. I'll just go through that before we check how we are doing with time. Dr. Ben Israel, or Israel Ben, pardon me. Thanks, Prof, for this presentation. Please, what's your take on the use of regorafenib as a multi-receptor blocker in treating EMS colorectal cancer side by side? And is dostarlimab better?
Yes, dostarlimab is better. These are programmed death receptor inhibitors. And regorafenib is one of the earlier ones that were produced. I think it's used more for malignant melanoma, some other cases, some other types of malignancies. And but dostarlimab, which has the same property with that, just has been shown to be a lot more effective, just working like magic. So let's keep our eyes on the dostarlimab for now and see how it goes.
Thank you so much. Yeah, just for the time. Dr. Adejumo also asked a question here. Maybe Dr. Adejumo, do you want to say yours? Yeah.
Okay, thank you very much. Prof, thank you very much for the discussion. It's quite enriching. First of all, I want to appreciate everybody that has contributed, and there is a recurring question or recurring comment by many people concerning diagnosis vis-a-vis histopathology, immunohistochemistry. Permit me to say that the people concerned, that is the pathologists, are not even here in this meeting. I personally sent out the notice of this meeting to their secretary or their president of the National Association of Pathologists. But surprisingly, I don't think any pathologist is in this meeting. And if we remember some times ago, it was even a pathologist that even presented a very robust presentation on this forum concerning staging and all those things. But after some time, they stopped coming. So I think we need to drag in pathologists so that we'll be at the same level when discussing some of these challenging things. And just like our Professor Irabor said, we have some difficulty in establishing diagnosis. And personally speaking, I think if we can bring in private sector, because I think the burden might be too much for many government hospitals to bear. So if there could be collaboration between the government sector and the private sector in establishing diagnosis of colorectal cancers and also other cancers as well, I think it will go a long way. And probably this will foster the creation of regional laboratories where pulling of samples will be easier instead of sending it to a central national center. So that is just my own perspective of that. Then concerning screening colonoscopy, really, we've been on this issue for quite some time, and not only screening colonoscopy, other related interventions. And I think we have saddled one of our trainers on this platform with the responsibility to coordinate how to look into some common colorectal disorders in Nigeria and to come out with a template on how to screen, how to treat, at least considering our local problems and peculiarities in Nigeria. So I'm sure that very soon, even someone like Professor Irabor will be contacted with respect to that. Now, concerning the outlook of colorectal cancers in Nigeria as presented by Prof. Prof, from your practice and experience over the decades, is there anything that you can attribute to the prevalence of more rectal cancers than colon cancers in Nigeria? And also, could we attribute this observation to probably some socio-cultural practices or some tribal factors vis-a-vis genetic involvement? Because I know that I came across an unpublished report some times ago that a certain area in the north central Nigeria has more prevalence of this colorectal cancer problem. So I don't know, from your experience, do you think that there are some specific factors responsible, especially for more prevalence of rectal cancers in Nigeria from your experience over the years?
Thank you for that question. First of all, indeed, the first thing you mentioned, I've noted it down here, that how come this association doesn't involve pathologists? Because if you are talking about trying to get this test done, then the pathologists themselves will be able to advise us on which labs to use or not. If you talk about private sector, there was one time I had a meeting with a lab in Lekki. It's a new lab, and they seem to be able to do all these things, even pyrosequencing. But I have a feeling that they'll probably send the samples abroad. But the problem was the logistics, because I was saying that, okay, supposing I operate, how are you going to collect the sample? They said they will send a dispatch rider to Ibadan. I said, it's not economically sound. And what they were even charging, you know that these people are out to make a business, and most teaching hospital patients will not be able to afford. Now, having said that, this concept of rectal cancer has always intrigued me. I've been thinking about it for a long time. Now, most of what I want to talk about is just anecdotal, it's just my own feeling, okay? In the sense that maybe 40 years ago in Nigeria, we hardly saw colon or rectal cancer. Okay, now we talk about change in diet, and then our colonic microflora is changing, and now we're having polyps and things and unstable epithelium, fine. But this concept of rectal cancer, what I really believe is that for most Nigerians now, more fecal matter stays in the rectum more than the colon. In other words, yes, ordinarily, when things get to the rectum, you need to go and evacuate. If you go to the villages now, there are no toilets. People just go to the bush when they feel pressed and they evacuate. But in the cities, you may have to wait until you get to a toilet or until you get home. In so doing, you have more time, the carcinogens have more time to interact with the rectal mucosa. Again, that is just my feeling, in the sense that areas in which you have a lot of public toilets probably have a very low incidence of rectal cancer, because anywhere you go, you can always pop in and evacuate. But here in sub-Saharan Africa, because of civilization, you are now having a white-collar job. You may have to hold your fecal matter until you have a chance to go to a toilet or you go home. Just my feeling. But it needs to be looked into. Why should Nigerians or Africans have more rectal cancer than colon cancer? Just my feeling. Thank you.
Yeah, thank you very much, Prof.
Thank you very much. Yeah. I'm just based on the conversation we're having and what Dr. Adejimo said there. I think the way we can involve the histopathologist in this meeting is for each of us to invite our histopathologist, because we have them in our hospitals. Go out for a cup of tea or I'm talking of tea now. Go out for a drink or something with them and just bring the argument or the case to them so that you can have buy-in from them. So it's on a one-to-one basis rather than going through the association. There is no personalization of that. But if you invite your personal, or not your personal, but your colleague in your hospital to the meeting, that way we can get more buy-in. So let's take that as a challenge, that we invite our pathologist. And I think that would be the starting place, and to get them. We need them in this meeting. We absolutely need them, because we can't do it alone. And then we also need to think of the medical oncologist, who will be the people treating like this kind of high-end drugs. These are not drugs you play with. So for somebody to prescribe a medication that is costing $2,000, it has better been somebody who is a specialist in that area, who has the wherewithal to deal with the complications that may arise or the toxicity. So we should get the histopathologist and the medical oncologist to actually come in and have a conversation. That is why we named this Association of Colorectal Disorders. So it's not the Association of Colorectal Surgeons. Let's just try and do a bit more of that. How are we doing with time? Are we?
Yeah, I think we have actually run out of time by about 2-3 minutes.
All right. So I hand over to you.
Okay, thank you. Thank you very much, Dr. Iguari. Apologies for joining late. It was as a result of a connectivity problem. On behalf of myself and the association, I actually want to thank Professor Irabor for this wonderful presentation. Though Professor Irabor is like a father with many children that he doesn't know, of which I am one of them. I may not have a very close contact with him, but we have read a lot of his publications during residency, and up to now, we are still reading about his publications. Prof, I really want to appreciate you and thank you very much. I also want to appreciate everybody that has taken time out of our busy schedules to attend this meeting. This meeting is quite inciting, and I believe we will still bring Prof again for some robust discussion on some of this genetic testing and diagnosis, considering personalization of treatment in our patients in Nigeria. This is a new horizon that we have to explore to the fullest. I also want to thank our diasporan contributors, Professor Ray Ofo, all the way from Florida. Thank you very much, sir. And we also congratulate you on your recent elevation to the seat of a professor. Dr. Iguare and Dr. Augustine Erotulam, I really want to appreciate you. Next month, June, is the middle of the year, and we are going to have our mid-year OGM next month, coupled with our clinical meeting. So we are going to communicate the details across over the next couple of weeks. And I believe during the OGM, some of the things that we have been talking about, considering our activities and administrative involvement, will be discussed extensively for input and also to give an account of our duties since the beginning of the year. So be that as it may, other information related to that will come. I want to thank everybody once again and wish you a happy night rest and a wonderful week ahead. Thank you and a good night.
Thank you.